Hey guys, can you see me? Can you hear me? Jain Medical is a mishap, so I will be going with the types of necrosis only. I'll make sure that they will change the heading and title tomorrow. That tomorrow's class will be apoptosis. There's no missing lecture. I think there's a miscommunications in the schedule. Fine. Okay. If I'm audible and visible, do let me know. Good evening, Sugata. Good evening, Jain Medical. Jain Medical, what's your name? Good evening, Prithvi. So let's start. So we're going to start with the types of necrosis. Fine. Okay. So can anyone tell me what are the types of necrosis you already know? Like any types of necrosis, hello RP. Anything which comes to your mind. Hi Vinay. You might have heard about necrosis, the coagulative necrosis, the liquefactive necrosis, the fibrinoid necrosis, fat necrosis, and a variant of necrosis called caseous necrosis, right? Happy Sarsaj Bida Kumar. Okay, good evening, Ankita. Okay, perfect. Right, so see, these are a few types of necrosis which are there. Now, what we're going to do is we're going to see why these necrosis are different first. Hello, Mahir Ahmad. And why we need to learn about each different type of necrosis and where all we can apply. Like when I see a disease, what type of necrosis will I see in microscopy? Where all we can apply is what we're going to see in this lecture. Fine. As usual, I hope you're in the Telegram group and I hope you got this basic template of what we're going to talk about today. Fine. Hello, Siddhartha. So most of the time, keep this in mind, whenever something comes on the first as a title, that will be the most common. So definitely coagulative necrosis is undoubtedly the most common subtype of necrosis, because coagulative necrosis is caused due to infarct or extreme amount of ischemia, right? There's no blood supply at all. If you remember yesterday's class, I told that what's the most common cause of injury? Anyone? The most common cause of injury by default is hypoxia. So when hypoxia is the most common cause of cell injury, is in fact it will definitely be the most common type of irreversible cell injury or cell death, that's necrosis, right? Perfect. So infarct of any solid organ, right? Infarct of any solid organ, you will end up in having coagulative necrosis. It could be your kidney, it could be your spleen, right? Any solid organ for that matter, right? Any solid organ, in fact, you will end up in having coagulative necrosis only. Whatever solid organ comes to your mind, you can take, right? Can anyone tell me what could be the etiology of the coagulative necrosis, or let's say what would be the etiology of kidney infarct? Anything which comes to your mind, because we know what's an etiology. I think we have learned a little bit about the etiology when we discussed about cell injury. It could be an atherosclerosis, right? A kidney artery can definitely have an atherosclerosis which can completely block the entire thing. And is it I don't know why my video is paused. Okay, guys, can you see me now? Is it fine now? Okay, great. Abhishek, no, my network speed is problematic. I think it's fine now. Fine, let's start. So, for guys who are starting from now, so we have just started the types of necrosis. The most common is coagulative necrosis, and the cause of the etiology being infarct of any solid organ. Fine, great. Let's start. So the mechanism of action is protein degradation. So entire cell protein, entire everything will be destroyed. Primarily, the protein degradation is the mechanism of action of coagulative necrosis. has one very important point in case of coagulative necrosis, which is architecture being maintained. There's also one fancy term given along with that, which says ghost cells. Audio is clear, right? Fine. Which says ghost cells are seen in case of an coagulative necrosis. We'll see what do we mean by these ghost cells and what do we mean by architecture being maintained, right? For understanding this, let's go to two classical images given in Robbins under the term coagulative necrosis, right? Let's look at this. This is definitely an infarct of the kidney. Most of the infarcts will be very well defined. We'll look at how to know the different types of infarct in the 4th chapter of Robbins, right? So this pale area here is infarct. Is actually kidney. You can see the medullary structure here. Is actually the pyramid here. All those things you can see that. That's a cut surface of a kidney, right? One half of a cut surface of a kidney. That's an infarct. If you look at the gross, and now let's look at the microscope, right? I am sure you must have learned about the histology of kidney in your first year, right? So can anyone tell me what structure is this? Whatever comes to your mind, tell me what structure is this? What's the structure? Can I say it's glomerulus? Yes. So that is a glomerulus, right? Perfect. So if you look at this glomerulus, can I also say that this particular glomerulus, you have the blue color things or the nucleus is seen? Yes, no. That's the entire glomeruli, right? So this glomeruli, do they have the blue color cells or the nuclei? It is seen. So can I say this glomeruli is a viable or not a dead glomeruli? Is that statement right? This is undoubtedly a viable or a normal glomeruli, right? Perfect. So if that is a glomeruli, can anyone tell me what this structure is? It's adjacent to a glomeruli and it's rounded in shape, more or less round or oval structure. Can anyone tell me what structure is this? If it's a kidney biopsy, you have a glomeruli here. So what structure is this? Perfect. This is a tubule, right? Any tubule, PCT or DCT, will not go into the details of it now, right? Let me zoom this PCT or DCT, whatever it is. Tell me now, if you look at this tubule, is the tubule having any blue dots, or is it viable, or is it dead tubule? What is your take? What is your take on that? Viable tubule or a dead tubule? It's not having any blue color, which means pycnosis, karyolysis has happened, and this is perfectly a dead tubule, right? Perfect. Now, tell me, even though it is dead, right? It's not a viable tubule, it's a dead tubule. Can I say still the shape of the tubule is maintained? Is that statement right? It's a dead structure, there's a dead structure, there's a dead structure. All these are dead structures here, whatever I'm taking here, but still the shape is maintained. It's still looking like a tubule, right? Perfect. That's what I mean by architecture being maintained. I can say it's a dead tissue in spite of being dead. It will have its same architecture. Tubule will be like round structure. That's what I mean by architecture being maintained. That's a classical term given for coagulative necrosis, right? Now, when you look at ghost cells, ghost is nothing but, if you remember Scooby-Doo, you have the Casper ghost, right? It'll have a shape, but no life inside. In other words, this architecture has a shape, only shape. It's looking like a tubule, but it's having no life. It will not function like a tubule. That's why we have an analogy called as a ghost cell, right? Ghost cell being is nothing but architecture being maintained, fine. That's classical for a coagulative necrosis, right? Now let's look at liquefactive necrosis, fine. How many of your classes they have taken liquefactive necrosis in your college? Or if you have read liquefactive necrosis, can anyone tell me which organ infarct will have liquefactive necrosis? There's one organ infarct which can have liquefactive necrosis. Brain or your CNS infarct, right? So brain infarct or the CNS infarct will have liquefactive necrosis. Perfect, amazing, great. Now let's go back to your anatomy dissection hall. Have you touched brain parenchyma? You might have touched brain parenchyma, right? Pancreas will come into it, Jain Medico, soon. You must have touched brain parenchyma by default. Soft, firm or hard? Brain is very, very soft, right? Brain is made predominantly of the phospholipids, the fatty background. Doesn't mean that when you eat KFC chicken, your brain will grow, right? It's a different fatty acid, omega-3 fatty acid. That's why in your biochemistry, you've written essential fatty acid. Omega-3 is very, very essential for neuronal development, very, very essential for my brain development, right? Now, the mechanism in case of a coagulative necrosis, primary mechanism is protein degradation. Now tell me, can a protein degradation destroy fat? Can it destroy fat? It cannot destroy fat, right? By default, it cannot destroy fat. So which means, what do I need to destroy fat? What do I need? I need an enzyme. Which enzyme? Which enzyme can destroy fat? Lipase, right? So I need lipases to destroy fat. So I need lipase from some place so that my brain parenchyma can easily be destroyed, right? Now I'll ask you a simple question. Which cell organelle inside the cell has lipase? There's one organelle in my body which has lipase inside. Which organelle is that? That's your lysosome, right? So there are two ways by which I can have liquefactive necrosis. The basic mechanism here it is enzyme activation. Here the main mechanism is not protein degradation, it's an enzyme activation, right? So either it could be coming from my lysosomal enzymes that can get activated. So we call it the term as autolysis. Have you heard about the term autolysis? Automatically an entire cell destroys, right? Or it can come from outside, which can come from WBCs. Because WBC also has good amount of lysosomal granules, they come from WBC, which is coming from outside. We call it heterolysis, right? These terms are not used these days. It is not there in Robbins, but these are older terms. If you want, you can write for more marks, fine? So I can either destroy the entire tissue from WBC entering the tissue and causing death, or by the own cells, autolysis, lysosomal enzyme can happen, right? So I need enzyme activation for me to happen, right? Now, let's take a little bit back and also let's fill 2 and 3 as well. If WBC is going to have lots of lysosomal enzymes, can I say if I have a condition with very high amount of WBCs, can that cause liquefactive necrosis? Yes or no? I'm having some random condition, but I'm having so many WBCs, so many neutrophils. Definitely many enzymes will be secreted. Is there a possibility for us to have liquefactive necrosis? Yes, right? So can anyone tell me what is the name given to a condition where I have a tiny swelling in the hand, that swelling has lots and lots of WBCs, neutrophils or pus cells. What do we call that? Have you anyone heard about a statement called as an abscess formation? You might have heard about abscess formation, right? So an abscess formation also by default will have liquefactive necrosis, because in an abscess formation, I will definitely have lots and lots of pus cells or lots and lots of WBC. The abscess can be in the CNS, abscess can be in the lung, kidney, anywhere in the body. If there's anywhere in the body when you have abscess, it will undoubtedly result in liquefactive necrosis, right? Third thing, a couple of you guys said pancreatitis, right? What is the mechanism of pancreatitis? It's autoactivation, right? Pancreatitis main problem is all the enzymes of pancreas gets activated, it will digest the entire pancreas. That's the mechanism of pancreatitis. Can I say lipases are secreted by pancreas also? Is that statement right? Obviously, right? Lipases are there, apart like trypsin, chymotrypsin, we have lipase and pancreatic lipase, right? So that also can liquefy, right? So in patients with acute pancreatitis, I will have liquefactive necrosis, fine? In the case of an acute pancreatitis, abscess formation and infarct of brain, you can have liquefactive necrosis. I'm just going to write one more thing for abscess of brain, abscess of any structure, wet gangrene. Wet gangrene is nothing but a gangrene with a suppurative inflammation. When a gangrene is filled with pus, we call it wet gangrene. When a gangrene is having not much of pus filled thing, we call it dry gangrene. Dry gangrene is coagulative necrosis. I don't have blood supply to my finger, the finger dies. That's gangrene. Gangrene is a gross term. When the entire structure becomes greenish, blackish in color, we call it gangrene. Diabetic foot can have dry gangrene, but when it's infected and having suppuration, when pus is oozing out, we call it wet gangrene. Whenever pus comes, more WBCs, which means liquefactive necrosis, right? And here, now tell me, first, why did I call it liquefactive? So the premise here is lipase activation, fat destruction. That's the premise here, right? Perfect. What will happen when you destroy or when you digest any fat? Let's take a simple example. You must have seen at your home butter being boiled. What will happen when butter is boiled? Butter is fat, right? When I destroy butter, it becomes liquid, ghee. That's why we call it liquefactive necrosis. The entire brain will be a solid brain will be made into a liquid form. Will it become like a ghee? Fine. Sogata, abscess is anything which has good amount of pus. We call it an abscess, right? That's all. When you have a tiny infection of the finger, we call it an abscess, right? Okay. So if the entire thing is going to become a liquid, will I have the architecture? Imagine this entire kidney becoming a liquid. Will you have tubules? Will you have glomerulus? Nothing will be there, right? So the architecture will be lost, and there'll be no ghost cells seen, because the entire structure will become a liquid like this. There's an image from Robbins. This entire brain parenchyma is liquefied. It's kind of become like a liquid. There's no structure there at all. Entire structure is destroyed. Architecture is lost, right? That's what happens in liquefactive necrosis. Perfect. So you know about coagulative, you know about liquefactive, right? Let's take about caseous. Caseous necrosis as a separate type of necrosis is contemplated. It's some books say it's a subtype of coagulative necrosis. Some books say it's a pure caseous necrosis. Caseous means chalk white, right? So that's what caseous means. Fine. Now tell me, there's an image from Robbins. There's a lung specimen of tuberculosis where you can see this whitish areas here. That's your classical caseous necrosis, right? Now tell me, what do you think will happen when you look at this whitish area in the microscopy? Will it be white in color or pink in color? How to look in microscopy, white or pink? Necrosis microscopy is almost always only one color. What's the color? Pink color, right? It will be pink in color. It will not change, right? Because in microscopy I have eosin and hematoxylin. I'll have only pink color. Now tell me, so caseous, the term caseous is a gross finding or a microscopic finding? I can see chalky white color with naked eye or in the microscope. It's always for a gross finding, right? The term caseous necrosis is a gross finding, because only in gross or in naked eye I can see the chalky white nature. I cannot see in microscopy. Microscopy, it is still a necrosis, but it will be pink in color only, right? So microscopy, what can happen is, it will be like a coagulative necrosis. It will be pink in color with little bit of granularity. I'll tell you why the granularity happened, fine? Okay, that's how microscopic caseous necrosis looks like. Most of the time when there's caseous necrosis, microscopy I cannot call it caseous, but still most of the textbook uses caseous, so I'm calling them as caseous, right? So caseous necrosis in microscopy will almost always have one more structure called as granuloma. We'll read what is a granuloma when we come to inflammation chapter and chronic inflammation. Granuloma will be seen, right? What's the diagnosis? Like Prithvi already said, till you are in the field of medicine, whether you are in India, UK, USA, whichever part of world, there's only one diagnosis when you see caseous necrosis. I want you to never forget tuberculosis, right? Whichever part of the world you are, TB will always be there. India, they might say poor socioeconomic status, but TB comes. UK has HIV/AIDS and USA has HIV/AIDS. Still TB comes. TB rules. At any point of time, TB is going to rule. If you improve the socioeconomic status, people become stupid. If the socioeconomic status is low, obviously TB will thrive, right? TB by default is the first diagnosis which you have to think when it's a caseous necrosis. If TB is ruled out clinically or in MCQ, think of few other things. Histoplasma. Only if TB is ruled out. Salma, मेरा हिंदी थोड़ा खराब है, so you ask your doubt in English. I'll try to explain in English. Fine, okay. It's not so good. Fine. Histoplasmosis or coccidiomycosis. Only once you rule out tuberculosis, especially coccidiomycosis, histoplasmosis might be useful if you are writing USMLE exam, because they feel that they don't have tuberculosis, but still, even in US, the first cause of caseous necrosis is still tuberculosis. They think they don't have, but they have. That's the most common cause. But keep in mind, if you're writing USMLE exam, PLAB exam, keep this in mind. That might be a common cause. Fine. Okay. That's about caseous necrosis. It's a type of your coagulative necrosis only. Same. The only color is chalky white and gross, right? Next, we'll go to fibrinoid necrosis, right? I have told you last time itself in a lecture that name is everything. If you find something unique in the name, read the name, right? BCG vaccine, Prithvi, can not prevent tuberculosis. BCG vaccine can definitely reduce the death or severity of tuberculosis. You will learn about BCG vaccine, its effect, once you go to your final year. BCG vaccine you give, chance of TB, meningitis and miliary tuberculosis less, but still TB can come, right? It's a good vaccination, not efficient enough to eradicate tuberculosis at this point of time, okay? So everything is there in the name, right? So oid means like, okay? So oid means like. Whenever you see the term oid in any medical term, it means like. Fibrinoid means fibrin like, right? Lymphoid means lymphocyte like. right? Colloid means collagen-like. So what do you think about thyroid? Thyroid means shield-like, right? It's a shield-like organ. Thyre is shield in some Greek or Latin word, right? So oid means like, that's all. So fibrinoid means it's a fibrin-like necrosis, right? So you completed your first year. I'm sure you'll answer this question. Where do you see fibrin? Don't say from fibroblast. Fibroblasts do not secrete fibrin. Fibroblasts secrete collagen. Fibrin comes from fibrinogen. Fibrinogen is getting converted to fibrin or fibrin. Where do you see them? You see them in blood clot, right? Only when there's a blood clot, you will have fibrinogen or fibrin. When will you have a blood clot? Like Jane Medico said, when my blood vessel is injured. That's all. So fibrin-like necrosis is almost equivalent to a vessel wall necrosis. That's it. Anytime, any point of time in my body, when my vessel is injured, it gets destroyed by fibrinoid necrosis or a fibrin-like necrosis. That's all, fine. That's how fibrinoid necrosis works, fine. Now, let's have a quick look about, you are going to tell me the causes of fibrinoid necrosis, fine. Okay. You tell me the causes or things about fibrinoid necrosis, right? I told you it's fibrin-like necrosis, vessel wall necrosis, right? So conditions when you see fibrinoid necrosis, can I say in any vasculitis I'll have it? Vasculitis is nothing but vessel wall damage or vessel wall injury, right? Any vasculitis. I am not pinpointing one vasculitis. It could be polyarteritis nodosa. It could be giant cell vasculitis. Any vasculitis, fine. Okay. Any vasculitis I can have. Atherosclerosis I can have, right? So anything which is involving vessel wall I can have, right? So you will read something called as an SLE. We'll definitely read about SLE soon. Systemic lupus erythematosus. It's also a type of vasculitis. Like Jane Medico said, RHD is your rheumatic heart disease. In your rheumatic heart disease, this also you will read very soon. Or if your medicine posting is started, you might have heard about that, right? Rheumatic heart disease, there's a structure called as an Ashoff body. In Ashoff body, this also we'll read when you go to heart chapter. Again, heart is considered as the biggest vessel. It's a very big vessel. It's also like a vessel. In my vessel, I have intima, media, adventitia. In a heart, I have endocardium, myocardium, pericardium. It's the same, similar structure. I'll have the same thing, right? Also, you have a condition called as a malignant hypertension. So in malignant hypertension also, you might have fibrinoid necrosis, right? I'll give you a simple example. Which vessels are called as resistant vessels? You might have read this in your first year. Resistance vessels. Is it a capillary, vein, arteriole, artery, which is called as a resistant vessels? Arterioles are called as resistance vessels, right? Arterioles are called as resistance vessels, right? Okay, now let's say that this patient with malignant hypertension will have a blood pressure of, let's say, around 200 millimeter of mercury. Do you think a arteriole can tolerate 200 millimeter of mercury or it will burst? Arterioles by default will burst, right? It will burst because it cannot tolerate that much amount of pressure, right? So in an arteriole burst, it's a vessel wall, it's getting burst, so obviously you'll end up in having a fibrinoid necrosis only, right? So malignant hypertension is an extremely high amount of blood pressure which will definitely result in burst the blood vessel. So obviously ultimately the blood vessel is being damaged. That's how we identify it's a fibrinoid necrosis, right? Just remember, while revising, you need not read anything of this. Fibrin-like necrosis seen in vessel wall, any vessel wall injury will cause fibrinoid necrosis. That's enough, right? Now this image is from Robbins, right? Tell me what color is this? We're going to go with colors. Colors are the easiest way to diagnose things. It's an easy one, right? It's a red color, right? What's red color in my body? Blood. Blood will be seen only in a blood vessel, right? So please don't say that it's a blood vessel. I will identify tunica media and then diagnose it. You can't in real life. I have a lumen in the center, some round structure, blood vessel, or I have blood in the center, round structure, blood vessel, right? So in this blood vessel wall, so this is the wall of the blood vessel. Can I say I'm having this pink color structure? Pink colors, fibrin or necrosis. This is a fibrin-like necrosis, so we call it a fibrinoid necrosis, right? I have a fibrinoid necrosis in the pink color wall of the blood vessel. That's how your fibrinoid necrosis looks like. Fine, perfect. So you're done with the fourth type of necrosis as well, right? So we know about liquefactive, coagulative, fibrinoid, and caseous. Last but not least is fat necrosis. Fine. So fat necrosis, there are actually two examples of fat necrosis. I think in Robbins, one type will be much more well explained. I'll try to explain both of them. Fine. One, I'm going to call it a traumatic fat necrosis. It's trauma induced. It's not very difficult to remember this. When I have a fat rich structure, I'm going to damage it. Will the fat die? Obviously, it will die, right? Breast parenchyma, gluteal region, belly fat. I destroy it, it will die. It's trauma induced necrosis. The video is lagging. Just give me a second. Is it better now? Okay, fine. So it's trauma induced necrosis, fine. So traumatic fat necrosis is due to trauma. This can happen in any organ rich in rich in fat, which could be a breast parenchyma, which could be a gluteal region, which could be abdomen fat, anything. Any organ which is rich in fat, when it's destroyed, it will have fat necrosis. As simple as that, right? Let's assume you must have got injections, IM injections, gluteal injections by default, right? So when I'm going to inject using a needle in the gluteal area, will I damage the fat there? I will. It will cause necrosis. Insulin injections given in the abdomen cause necrosis. Breast, I do a biopsy, I take an FNAC, will cause necrosis. It's trauma-induced necrosis, that's all. That's one subtype, traumatic fat necrosis, right? Second, I have something called an enzymatic fat necrosis. Okay, it's an enzymatic fat necrosis. This is what will be more explained in Robbins. Even in Viva in first year, this will be more commonly asked. But when you go to final year, traumatic fat necrosis is more important. Okay, thank you, Chaitanya. Fine. So enzymatic fat necrosis, let's take the same condition of an acute pancreatitis. Fine. So when you take acute pancreatitis, like we already read, what type of necrosis will be seen in acute pancreatitis? Coagulative, liquefactive, fibrinoid fat. Acute pancreatitis will have liquefactive necrosis, right? Because the enzyme lipase will come outside, lipase will destroy everything, which makes it liquefied, right? So acute pancreatitis per se will have liquefactive necrosis, right? Let's make that clear first. Acute pancreatitis will not have fat necrosis, they'll have only liquefactive necrosis, right? So now the entire pancreas is liquefied. Can I say the fat lipase can leak outside? Because necrosis is nothing but damage to the cell membrane, right? Because of this, the lipase will definitely leak outside. Once a lipase leaks out, it will move into the omentum. Because from the pancreas, it can seep outside to the omentum. It can go into the peripancreatic fat, right? Because surrounding the pancreas, we have fat. So the lipase can move outside into the omentum. Lipase can move outside into the peripancreatic fat, right? It's a lipase and this is fat. And this lipase can cause fat necrosis. Fine. So the lipase will definitely result in a fat necrosis. Fine. So that's what happens in case of fat necrosis. Fat necrosis happens in case of an omentum and in the peripancreatic fat, and not exactly in the pancreas. In the pancreas, we'll have liquefactive necrosis, right? T, I am Dr. Ranjith. Please introduce who you are. Fine. So this is what happens in case of an your fat necrosis. Fine. This is an image from Robbins. This is an omental tissue. So you have lots and lots and lots of tiny things here. I will talk about this very soon. Fine. Now tell me, what do you think is the most common ion in irreversible cell injury? What do you think is the most common ion in irreversible cell injury or cell death or in necrosis? What's the most common ion? Sodium, calcium, right? Perfect. Let's keep that here. I'm having calcium here. Fine. Okay. So let's say calcium is the most common ion by default in any irreversible cell damage. Can I say that calcium is obviously the most common ion in fat necrosis also? It is, right? So let's say pancreatitis is due to alcohol. Alcohol is one of the important causes of pancreatitis. So alcoholism is acute or chronic, or will it come recurrently again and again and again? Alcoholism is undoubtedly chronic, right? It's not acute, it's definitely chronic. It's there throughout life, right? So now, will pancreatitis stop once, or it will happen, it will destroy every time the person drinks? Person drinks, pancreas destroyed. Person drinks, pancreas destroyed. Recurrent, again and again and again, right? So every time when the lipase leaks outside into the omentum, every time the fat will undergo necrosis. So can I say there might be little bit amount of your calcium deposited every single time on the omentum and the pancreas, because my neutrophils cannot completely remove. It will remove slowly, second hit, remove slowly, second hit, right? So when it is chronic, what happens is the calcium will bind to the fatty acids. It kind of forms like a soap. They give a special name called as saponification. Okay, or in other words, you'll have omental calcification. It's a calcific deposit, that's all. Along with the fatty acid, they bind and it causes calcification, right? I am not into NEET UG. There are many good teachers for NEET UG. This is if you enter when you enter MBBS, we'll definitely help you reading MBBS topics, fine? Okay, that's what is here, right? Now I'm going to ask you a different question. Now tell me, is calcification seen only in fat necrosis, or it can be seen in any necrosis for that matter? Coagulative, liquefactive, fibrinoid, everything. Okay, Sunny, if you remember last lecture when we read about necrosis, we said that after the cell membrane is ruptured, the neutrophils or the WBCs will come and remove every cell debris. Once it removes every cell debris, calcium also will be metabolized. It will be used in some other way. It will remove the cell debris. It will take the particle, use the things. Otherwise, it will be thrown outside, right? That's how the circulation happens. All the cell debris at the end of cell injury will be removed by WBCs, fine? Can happen in any necrosis. Perfect. Second question. It can happen in any necrosis when it's chronic and repeated, or when it's acute. When do you think it will happen? Chronic repeated or is acute? I'll come to that, Siddhartha. It is chronic and repeated. It will not happen if it's acute, because only when it's chronic, I will overload or overburden the WBC's capability to remove calcium and to maintain homeostasis, right? That's why it happens, right? So that question is very good. Will a person with pancreatitis end up in having hypocalcemia? Actually not. I'll give you simple examples, Siddhartha. See, this is omentum calcification. Do you think it will involve few milligrams of calcium here, or many quantities of calcium? They are tiny calcification, right? Let's assume my body's calcium is getting deposited here. Will my parathormone come inside and cause homeostasis again? Regulated? It can. And this is not happening in a single day. It's chronic, repeated. So slowly it happens. So my body can easily take care of the ionic imbalance and you will not have hypocalcemia. Fine. Okay, great T. Again, still NEET UG, I am not much aware about that. You still have to ask the teachers who are teaching the NEET UG segment, fine? I can definitely help you with pathology and NEET PG, okay? So it might not happen. It will take its own long time to do that, fine? Okay, that's about your fat necrosis, right? So we have covered all the important 5 different types of necrosis. Coagulative, liquefactive. Sorry for the technical glitch here. I hope you understood things. You have the ghost cells, you have the clear wedge-shaped infarct, and you have liquefied thing because of lipase or an enzyme activation. Fine. Caseous necrosis, the white color, it's a gross terminology, not microscopic. Never forget tuberculosis. Microscopic will be same, pink and granular. Fibrinoid, oid is like fibrin-like necrosis seen in vessel walls. Every vessel wall injury will have fibrinoid necrosis. Even heart, that's your rheumatic heart disease, can also have fibrinoid necrosis. Fat is of two types. Traumatic, any trauma to any organ rich in fat can have traumatic fat necrosis. Any like enzymatic is acute pancreatitis, lipase goes outside, destroys the peripancreatic fat and the omental fat, and which results in that. Fine. That's about the different types of necrosis. Any doubt? Do let me know. If not, we'll call it a day. No doubts? No doubts? Always I say the same. Either everything is understood or nothing is understood. I hope it's everything is understood. Fine. If you have any doubts in any point of time, you guys are there in the Telegram group. Ping me. I'll try to help you the best way possible. Fine. Okay. See you tomorrow. Till then, bye bye. See you guys. Good night.